for being here on our third Grand Round presentation by the Essex County Hub. My name is Deborah Waxberg, and I am the project coordinator for the Hub program. The Collaborative Behavioral Healthcare Project Grant is funded by New Jersey's Department of Children and Family Services in collaboration with Rutgers University Behavioral Healthcare and Rutgers, New Jersey Medical School. The principal investigators on this project is Dr. Evelyn Orozco from UBHC and Dr. Dominga Padilla from New Jersey Medical School. Both have presented on why hub services are useful in assisting primary care physicians in meeting the emotional and behavioral needs of their patients. Over the last several months, the hub team has collaborated with Essex County physicians, some of who are here today, and we have received over 150 referrals from our community. Our presenter today, Michelle Piesky, has been instrumental in providing our team the resources and behavioral and integrative health care. Michelle came to UBHC almost about a year ago in order to begin her pre-doctoral psychology internship through the clinical psychology program at Fairleigh Dickinson. Her passion is to pursue a career in integrative healthcare. And today, Michelle will be talking about practical behavioral tools that physicians can utilize in their offices with their patients in real time. Please help me welcome Michelle Piesky.
Hi, thank you all so much. It is really my pleasure to be here. So let's get started on today's presentation. So the things that I'm really hoping that we will go over today, I don't think I can explain how you can meet all the behavioral health care needs of the children that you treat, but really to address some of the big ones and to give you a few simple tools that you can use in your practices and discuss other referral options as well. So I'm going to teach several brief interventions to treat subacute depression, anxiety, and other mental illness in particular. And I know that most of you, if not all of you, have gotten exposure to motivational interviewing. So I'm going to review some of those motivational interviewing tools that are most applicable for behavioral health needs and combine them with some of the other skills that we're going to go over today. So to start, Jane Doe walks into your office. Jane is a 12-year-old girl, and mom has brought her in to see you because mom wants to know, is she doing drugs? So you talk to mom, why do you think she's doing drugs? Well, she's not really going out with friends as much. She's not as interested in the things that she used to be interested in, and her grades have gotten slightly lower. So you do a few assessments. For those of you who may not be familiar with some of these screeners, the Hub has access to most of these, the PHQ-9, most practices use standard, and then these other ones we also provide. So you can ask Debbie afterwards if you have questions about them. But while they're sitting in the waiting room, you're doing other things, they fill out these screeners. Well, it turns out she's positive for mild depression on the PHQ-9. She's not endorsed any thoughts of death. Pediatric Symptom Checklist 17 asks about both internalizing and some externalizing symptoms. So she's got a low but significant internalizing score, and she does not meet criteria for attention or externalizing behaviors. The Kraft screens for drugs and alcohol, she's not endorsed either of those on this particular questionnaire. And the Adverse Childhood Experience questionnaire asks about adverse childhood experiences, and so she's noted 2 of them. Her parents are separated, and she has, in the past or present, lived with someone who's used drugs before. Oh, sorry, I meant to ask you. So what are some of the things that you're thinking about in your differential right now? What are your thoughts here based on this presentation that you see?
Depression.
Right, okay, so depression. This is a pretty straightforward example where I hope that depression is standing out. So that's definitely one thing that you want to ask for. Is there anything else that you're considering? Thinking about ruling out other things that you would wish we'd assessed for?
Learning disability?
Okay, certainly, right? If you're having difficulties in school, That could be contributing to mood problems, lack of interest, lower grades. Although if she's 12 and she was getting A's before, it's possible but less likely, but that's a good thought, right? We want to see how things have been in school previously. Yeah?
Anything going on with her peers?
Okay, so are there other things going on in her social life, right, that are contributing to what may be depression or subthreshold depression? Is she being bullied or something like that?
Someone in the back of the room there whispered abuse.
Abuse, okay, right? She didn't endorse it, but that mom's sitting right there next to her as they're filling out these questionnaires, so she may not feel comfortable circling that any type of abuse. Absolutely. So there might be other trauma that's going on. Drugs is a possibility too, right? Just because she's not saying that she's doing drugs. We always want to consider, is that going on? And of course, we don't know. In a 12-year-old, it's more than likely that there might be some kind of depression, even if there is drugs, because her peers are not all doing drugs yet. If it's a 16-year-old, that's a different story. But a 12-year-old, they're not usually all going out and drinking every night. So those are some of the things that I would be thinking about. Pregnancy, maybe, right? In this 12-year-old, it's possible. We don't know if she has reached menstruation yet, and that could certainly be causing some hormonal changes. So something else to keep in mind. Again, 12-year-olds are not often going to come into your office pregnant, but they could. So these are some of the things that I would be thinking about. But depression being the really obvious one that we're going to target today. So I'm not going to go through a lot of the other things, although a lot of the questions that you may be asking as you talk to her about some of these things, you might keep them in the back of your head and stuff might come out. So why is this important? I'm going to take a step even further back. Well, y'all are the gatekeepers. You are the ones who see most of the depressed kids. In America, most depressed kids don't make it to mental health specialists, and certainly not kids who are not necessarily experiencing greater degrees of depression, right? We're seeing some subthreshold or mild depression here probably. And yet almost 13% of teenagers in America are depressed, more females than males, and of those, 70% experience severe impairment. That is an overwhelming number. And so you can see this breaks it down a little bit in terms of by race, by age. It's starting around age 12. I know there's a laser pointer here. I'm just going to walk up to it anyway. It starts around age 12. It increases with age. But really, depression is a very common problem, unfortunately, in our teenagers. And it puts them at risk for all kinds of other things: suicide, substance use, problems in school, as was mentioned, all kinds of health problems, right? So you're going to see these kids, they're going to come in and have more and more physiological health problems as well. They're the ones who are going to use the most healthcare resources as they grow up. They're the ones who are going to see all kinds of providers for all kinds of problems. The two tie into each other. Pregnancy, and then, they're more likely to be depressed throughout their lives. And 60% of them don't receive any kind of treatment for their depression. 60% do not get any kind of treatment. Now, why might that be? There's a lot of barriers to receiving mental health treatment. We usually talk about stigma right away. At least we in the mental health community, we always talk about stigma. But I feel like that's not nearly the biggest issue. It's expensive and it's difficult. You can wait 6 months or more to get a referral. A lot of these clinics, especially the kids that we're seeing, if you don't have insurance, you only have Medicaid, right? You have to go someplace local, otherwise how do you get there? And then a lot of these clinics make you wait 6 months or more. You have to get a psychiatric evaluation. Well, if you're depressed in 6 months, it's either remitted or you want to commit suicide by then. You know what I mean? It's the kind of thing that actually requires more immediate treatment in order to address it. If you're going to wait 6 months off, there's also this whole thing where you're not getting out of the house and moving so much. Parents are stressed out. They may not take you. They don't often make these appointments. So it's extremely difficult in our healthcare environment today to get access to mental health treatment, to pay for access to mental health treatment. And then there's the stigma on top of it. There is still stigma in many communities. And so there's many advantages to addressing a lot of these issues in the primary care setting. Right? You're the main contact. You're the person they see, and they have a trusting relationship with you. They're going to listen to what you say. You're going to be in with them right away. They don't have to like go and complete some 2 to 4 hour intake assessment with a stranger, doing this whole thing, 30 minutes away. That's scary and intimidating and unpleasant at best, right? They're just talking with you, their doctor, with whom they have a relationship. And there's continuity of care. They've known you for years. You can keep checking up on them. You can do some watchful waiting, which more often than not, I don't talk about that because I feel like all of you have watchful waiting covered. It's a skill that doesn't need a lot of practice, right? Other than the anxiety of, not doing something for someone. But you're able to decide, you know what, I don't think medication is necessary, or I don't think this is necessary right now. Come back in 3 months and let's see what's going on with you. That's a really important intervention too. A lot of things, if something is going on socially in this kid's life and it resolves, then she's gonna come back in 3 months and be fine. So not everything requires a trip to a mental health clinic. So that's why you all are particularly suited for treating Jane Doe. So what are some of the things that you can do? All right, so you've screened her, and now you've done the very dangerous thing of assessing for depression, which is a huge liability because you can't ship her off and send her to mental health care quite easily if she needs it. And so now what do? Now you have this like mildly depressed kid, and how can you deal with it when you've got a million other kids who are waiting to see you in the waiting room? What do? Well, the best tool for depression is behavioral activation. It's fast, it's effective, it's easy if you can get them to do it. It's shown to have comparable effects to SSRIs. And so really all you're trying to do is increase patient activity and get them to do things that they enjoy doing or that they used to enjoy doing before they became depressed. All right, so you come up to Jane, you say, great, Jane, you're depressed. What you need to do is exercise 3 times a week, 30 minutes each time. Go, you're gonna be great. Just go and do it. How effective is that gonna be? Is she gonna do it? No, I see like, I see laughter over here and shaking of her head, right? How many times do you tell your patients, like, this is what you need to do? All you need to do is exercise. Eat well, sleep right, and exercise, and you're gonna be in so much better shape physically and mentally. Like, go be better. Yeah, no. So that's where it gets a little more complicated. If they would just do these things, then everyone would be healthy. So we break it into steps for behavioral activation. Okay, so step 1, you explain it, right? If you go out and do stuff, Jane, you're gonna feel better. Create a plan for change. So I want you to walk 3 times a day, 30 minutes a day, go. Problem solve. That's not gonna be a problem for you, is it? And create a follow-up plan. So I'll see you again next year at your well visit, yeah? Still not working. So that's where motivational interviewing comes into it. Motivational interviewing is a collaborative conversation to strengthen a person's own motivation for and commitment to change. You gotta make her want to go out and do this. You have to find a plan that is gonna work with her schedule, her needs, her interests. And this is particularly challenging with depressed kids or depressed people in general, because the urge is to like go isolate, go home, cry in your bedroom, and just like do nothing all day. So you got to come up with something that's going to beat that really strong urge. And so if you work collaboratively with Jane and you respect her freedom of choice, she's more likely to go out and do these things. And we're really lucky working with kids because you got other people in the family who are there with them that you can recruit along with them. Now, these people may be depressed and stressed and all kinds of other stuff too, and that's an issue for another day, but the more that you can get family members in, the more likely someone is going to be to kick Jane out of her bedroom and say, go do something, right? Now, motivational interviewing was originally designed for substance abuse issues. It's really useful in primary care settings for like everything though. So substance use and smoking cessation, obesity, treatment adherence. I was in a primary care setting and I use this all the time for patients with diabetes, right? All the time to work on diet, to take their metformin. Oh my God, like it's so helpful. Lifestyle changes more generally, and of course mental illness. So this can be used in conjunction with so many interventions. It's based on the stages of change, trans theoretical model of change, depicted here, where you go in a circle from pre-contemplation to contemplation, right? So Jane may not even be ready to make a change. You're trying to move her a step in the right direction. Depending on where you think she is and how likely you think she is to comply and how likely you think mom in this case is to make her comply if she's not going to, you might determine your next follow-up visit based on that, right? So if she's in pre-contemplation, she's like, no, I'm not doing this, then maybe she comes back in a few weeks and you push her a little further. If she's ready to take action, she's like, I'm really miserable and I don't want to do this and I like what you're saying, then maybe you give her a little longer leash because you think she's going to go out and do it. So it's important to keep in mind where you think she is and how likely she is going to be to comply with your recommendations. So there's 4 processes of motivational interviewing. They don't happen in a particular order, they happen all throughout. And so I'm going to go through them and talk about how, in this case, you can use these skills to get Jane to do what you want, basically. So engaging, you got to engage her throughout. And so they have the nifty mnemonic ORs. You do this by asking open-ended questions, right, to find out more information. And so this is really useful in the beginning. You have your screeners, you have the fact that mom thinks that she's using drugs, and so you can ask her, how have you been feeling lately? Right, as opposed to this says you're depressed, are you feeling sad? Then you get a yes or a no. It moves you along faster, but then you actually have more information that you have to collect along the way. If you ask open-ended questions in the beginning and then you kind of close it as your time is coming up and you need to move it on, this is a nice way to get the information straight from her. How are you feeling lately? What's been going on with you? How are things at school? How are things with your friends? And you might get a lot more information than you expect just by starting with this open-ended question. Or you might have a completely disactivated kid who says, fine, nothing. It doesn't always work, but it works better. Affirmations. So this is saying positive things to her. Thank you for coming in. Thank you for sharing that with me. I appreciate that. That was a really brave thing to tell me, right? Just peppering along the way with lots of praise. The more you praise her sharing information to you, the more she's going to open up to you. Affirmations, just be careful with a depressed kid, because sometimes we think affirmations is saying like, oh, you're so smart, you're so pretty, you're so, and if she's got really low self-esteem, that's going to turn her off right away. She's not going to believe you. So this doesn't necessarily mean complimenting her. It just means really praising the behaviors that you're looking for within the session. Reflections. So this is just taking what she said and saying it back to her. You could even do it in the exact same words she does. So if she says, yeah, I've been kind of sad lately. Yeah, you're feeling sad lately. Tell me more about that. Really, you can't do this enough. It helps patients feel heard. It helps you make sure that you have the correct information. I can't tell you how many times I've reflected back to a kid what I thought was a really obvious restatement of what they said. And they're like, no, that's not what I was saying. And I'm like, oh, okay, do explain. Like, what did I get wrong? So reflections are a great way to summarize information, check the veracity of it, and help the patient feel heard and keep going. And then at discrete points, as you're ready to move on in your assessment, you want to summarize what's been said, you want to highlight the change talk, and we'll talk about that, and move on. So that's a nice thing you could do. Okay, so you're feeling really sad, you don't know why, things are okay at school, you're having trouble sleeping, you're staying in bed a lot, and you just want to feel a little better. There's stuff that we can do to help you feel better. Let's talk about that, right? You want to resist the writing reflex, which is telling patients what they need to do, which is like just said, let's talk about what we can do to make you feel better. You need to go do some exercise. You need to take this medication. You need. Anyone have a parent or caring person in your life who for all the right reasons has told you what to do and you push back against it even if you know they're right in your heart of hearts, right? Like, gosh, you just need to go to sleep. It's late. What are you still working for? Listen, I got a lot of work to do. I got to stay up, right? Whatever it is. If someone tells you what to do and you have any ambivalence whatsoever, it kind of puts you on the defensive and you push back at them. And so we're dealing with kids who have a lot of ambivalence. We want to highlight that ambivalence and we want them to give you all the reasons why they want to change If you tell them what they need to change, they're going to give you all the reasons not to change, right? This is really tough for doctors. This is really tough for therapists. I am so guilty of this, especially as like the clock is ticking and I'm aware of it. I tend to start being much more directive, and that's when you get this defense coming up. So you want to elicit what they call change talk, not sustained talk. You want them to tell you all the reasons why they want to change. You also need to focus as you go through, right? You can't be like interviewing them forever because you got however many, 10 minutes till the next kid is up. So there are different styles of focusing. There's directive. I tend to fall in the more direct. I'm very guilty of this, right? I want to tell you what to do. I have all the plans. I'm the expert here, so like listen to me and let's go through this. And there's moments when you need to do that. That's a really important. We're going to shift through all three styles, but just be aware where you tend to fall. There's following, where you let the patient lead. I know in mental health sometimes we find people who do this a lot, where we just love to let the patients talk and they kind of explore on their own, and there's definitely a time and a place for it. And then guiding is this combination of both, and that's the blend that we're looking for. And so the strategies to do that, and as I said, this is where I am less strong, using hypothetical language. So instead of saying, let's talk about how we can change, it's, would it be all right to talk about certain strategies for how you could change? And it helps you both go through this journey together. Elicit, provide, elicit is a technique of asking for information, providing information, and then asking for more. So you're feeling really sad and depressed, tell me how you've been feeling, right? And so she shares, I'm like feeling all these different ways, I'm not sleeping, I'm not this, I'm not that. So would it be all right to talk about different ways that we could help you feel better? Yeah, okay, great. So let's move forward. There's this thing called behavioral activation. Let me tell you a little bit about it. Does that sound okay to you? Right? Even just checking in and asking a question at the end is eliciting information, keeping the patient engaged, and having her move forward with you. You always want her to be in charge, or him. I'm saying her because it's Jane. So the more autonomy you give your patient, the more she's likely to stay with you on this journey and not check out. And you also don't want to give her one option, right? The more options there are, the more things she chooses among, the more she's going to feel empowered. This is something I chose. This is what I want to do. Okay, so getting back to our behavioral activation steps. So what you're going to explain, this is the quick and dirty version, right? But you can explain it in a very motivational, interviewing kind of way. It sounds like you're not doing all of the things that you used to do. You really used to love hanging out with your friends after school, and you did all these different activities with them, and now you're just going home and like crying alone in your room. You know, sometimes when people are depressed, it feels really good to avoid the things they used to like, right? In the short term, the thought of going out and doing something is just overwhelming, and you're tired, you don't want to, and it feels really good to say, you know what, I'm just going to lay down. But how does it feel after you do that? How's that been working out for you? She's probably, if she has any insight, is going to say, you know, not so great. Sometimes they don't have insight and they don't give it to you. You say, okay, so what do you do when you go in your room and you don't go out with friends? What happens? What do you do in there? Nothing. Yeah, and like, you know, are you smiling and laughing? No. What kind of music do you listen to? Oh, I listen to Adele. Oh, okay, that's really positive and upbeat. You know, and you get from them that like she ends up like crying alone in her room, right? And so how do you feel afterwards? Did that make you feel better? No, it really didn't. So having her walk that path instead of saying, you feel worse when you do this, research shows us, she's going to be like, okay, nice, good for research. If you can have her tell you about her life and the fact, get to that insight that she really feels terrible when she goes home and cries alone in her room listening to Adele. That's going to be more meaningful to her. So then you could say, and the research shows, there's actually something pretty simple you can do to feel better. If you go out, if you fight that urge, I know you really want to go in your room and do nothing, but if you fight it, it actually can help you feel better. What do you think about that? So just because you go through this doesn't mean that she's necessarily going to be ready to change, right? And so you have to figure out where on that cycle of change she is. And you want to encourage her to come up to use language that highlights her motivation for change, and then that's what you're going to summarize and reflect back at her. So if she's like, I'm not so sure, like maybe I could go out and do something, but I don't really want to. You could say you're feeling ambivalent about it, but there's a part of you that really wants to change, right? You can summarize the parts you want to summarize. You don't have to give her all of it back. And so there are some techniques that are really effective and certain types of questions you can ask to promote change talk. Darn cats type questions, but especially darn we're going to focus on at this stage. So you want to ask questions that are going to highlight her desire, ability, reasons, and need. How would you like for things to change? If you could change your life, what would it look like? What would you like to happen? What do you think you could change? Ability, right? Like, what are you capable of right now? What could you manage? Because a lot of times, anything ambitious is going to feel too overwhelming. Well, maybe I could go out and talk on the phone, hang out outside of my room with my parents for a little bit. Something small, right? What's the downside of keeping things the way they are now? Reasons, give her reasons to change. Oh, well, right now things aren't really good. I really do want to make a change. What needs to happen? How important is it for you to get an A in your next report card, right? To change your grades, whatever it might be. You could also query extremes. What's the worst thing that happens if you make this and you try this? What's the worst thing that happens if you don't? Meanwhile, what's the best thing that could happen, right? What do you have to lose? Tell me about this. What were things like back then, 3 months ago? What was your life like? Was it better? Do you want to go back to that? What's changed since then? And if you did decide to make a change, what would you hope would be different about it? And you're not just asking these questions to get the change talk. You wouldn't ask all of these, obviously. I'm giving you lots of examples. Based on what you're looking for in terms of getting her to get activated, you're looking for examples as well of things that she can go out and do. So you're not just asking lots of questions and hoping she gives you reasons to change. You're doing all of this in the context of, listen, if we get you out doing things, you'll feel better. What kind of things did you used to like to do? How did that work out for you? Do you think you could do that moving forward? Okay, so tell me more about those things. And what's the worst thing if you go and try it? Yeah, okay, not so much, right? So then it doesn't work and you go home and you cry and you're exactly where you were. What's the best thing that could happen if you try it? Maybe you feel better, exactly. So it's all, I'm kind of giving you an overview here, but you do remain focused and you do remain mindful of the clock and keep it moving forward. And so you kind of have been moving from evoking to planning. All of this is happening simultaneously. You want to notice the change talk. If you have motivation that you're hearing from her, then you keep plowing forward, right? You don't have to do a formal assessment oh, did she give a D answer, an A answer? Any motivation, you can jump on that and push through. It's with the kids who are really I don't want to do anything. Oh, that's not going to work. You all know these kids, right? I can't do that. Oh, that's never going to work. That's when you step back and you do a lot more, right? You're not going to get too far. Lower your expectations. Get mom in the room or whoever is taking this kid into the office. Get them in the room. Get ideas from them. And really just plant a seed. Because you could tell her to do anything you want. She's going to go home and she's never going to do it, right? So that's when you want to think more about evoking and less about planning. If you have a kid who's giving you I could do this, then jump on it and move forward. Don't waste time with asking more and more questions about it. So this is kind of your decision tree, right? Is she ready to move forward or not? And you can usually tell pretty quickly. There are those kids who throw everything, shoot everything down. So you summarize all the change talk, right? So you said you're willing to do this. You want to do it because you want to feel better. You want to get better grades. You want to go to your friend's party this coming weekend. You'd be really sad to miss it, but you're not sure you're able to get in and go. Let's make a plan and get this to happen. So how do you create your plan? Well, you start real small. Choose 1 or 2 activities that this kid is going to do. Things that she used to enjoy. easy activities that do not require lots of changes to the routine. This is so hard in this community, right? Kids can't go out and play in the winter when it's dark outside as soon as they get out of school. They can't go off and like play by themselves, a 12-year-old. They can't walk in the streets themselves all the time. It can be really difficult to come up with a reasonable plan of something they can do, especially if parents are working and they just like get bused home or whatever. So sometimes this is bringing mom and dad in, or mom or whoever, and coming up with like, is there an after-school activity? Does the school offer anything? This can actually be much more difficult, especially in this community. Summer, it's nice, it's later, longer. They have more options available to them. A lot of these kids don't go to camp, they're home all day. That also can be really challenging in the summer though, right? So it's more difficult than you think to come up with an easy activity that a kid could do in this community. But try and come up with something, even if it's really small. Really small stuff, baby steps can go a long way. So try and find something that's not just a one-time deal. You want it to be part of a routine. The more routinized it is, the more likely she is going to be to keep it up. And again, start small. If the goal is too big, it's going to be overwhelming and she's never going to do it. Even if she says she's going to do it now, in the face of all of that deactivation, all of that, oh, I can't, I'm tired, I just don't feel like it. It's really hard to fight that. But if it's something small and something very easy to do, you could take those baby steps and she's more likely to say, you know what, I'll just do it. So the goals have to be specific. The more specific the goals, right? If you say, okay, so you're gonna go walking. You're gonna go for a walk. That's great. She's not gonna go for a walk, right? Where are you going for a walk? When? Tuesdays and Thursdays after school, you're going to go to the, playground, and you're going to just like walk from school to the playground and then walk back to school. That's a great plan, right? That's specific. It's realistic. You break it down into sub-goals. If she says, I want to run a marathon, you say, that's awesome. Have you ever jogged before? Oh, you haven't. So why don't you start by jogging half a mile? You know what I mean? Like, marathon training is not necessarily step one, and yet a lot of times people come in with these crazy goals. Is it achievable? You want them to succeed. If they fail, then it makes them feel worse, and then they're really unlikely to get up and do something the next day. So they have to have easy victories, especially in the beginning. And then you build from it. And it's got to be something that she can control. With parents' help, if parents are available or guardians or whoever, right, it's something that they are able to do. It can't be, well, the school has a soccer team, so I'm going to join the team and I'm going to do all that. Okay, do they accept everyone? Well, no, you have to try out. Okay, so that's a really good goal. What can you do in the meantime before tryouts? Maybe you could start practicing. That's something you can do every day. The more specific the plan, the more likely she is to do it. And if you write it down, she's likely to remember it, to do it. Put it on a prescription pad. That works so well. There's all this research. There's all this placebo research. It's amazing. If you wear a white coat, patients are more likely to feel better if you give them a placebo. They're more likely to adhere to whatever treatment you give them. If you give it to them on a prescription pad, like something that looks really official, they're more likely to do it. If you give it to them like messily on some sheet of paper, they're more likely to throw it out. So use all those tools you have available to you. I mean, dress however you want to dress, but write it down, make it look really official, like the doctor is prescribing this plan for you, because she's more likely to do it that way. Your authority really counts. And then you got to problem solve, and this is a step that I think we all skip a lot of the time. What's going to keep you from doing this? So we have this very specific plan. We wrote it down. It's on a prescription pad from this like fancy schmancy doctor. What's not going to work about this? Tell me all the problems with this, right? And a lot of the time it might be, well, I'm going to really not want to do it when the time comes. And she's not going to necessarily tell you that. You have to offer her some of these problems, right? What's going to come up? Logistically, is the playground open all of the time? Are you allowed to walk from the school to the playground by yourself? Oh, you're not? that plan's not going to work so well, is it? If you need a parent to come with you and your mom's working at that time. So logistical things, but also what are the thoughts that are going through your head when you're feeling really depressed? What do you tell yourself when this kind of stuff happens? You say to yourself, I just want to go home and cry. Whatever the thoughts are, right? Like, nobody loves me. I really just don't want to do this. What are the feelings you have? What makes it difficult for you to get out? You're not getting out and doing stuff now. What's keeping you from doing all these things? Okay, so what are you going to tell yourself when those thoughts come up again? What's something you could say to yourself that will be motivating? And then you can offer suggestions, but then check in and be like, and is that going to work? Right? If you tell yourself, I can do this, like, that may not work. You could say, I can do this all you want, but I don't want to, and I'm going home, right? So check in with her and make sure whatever problem-solving plans you have, keep it collaborative, keep checking in, elicit, provide, elicit, right? What's the problems here? Here's a possible solution. Does that work for you? No? Let's try something else. What do you suggest? And again, recruiting the family to help is clutch because you have this huge resource and you're much more likely to get treatment adherence. If mom is in the room with you saying, we can make this work, oh, yes, you're allowed to go to the playground. Don't tell the doctor this. That's not true, right? Like, so many times mom's like, no, that could definitely work. No, you could do this. So get everyone involved and make sure it's a collaborative discussion throughout of how to make this possible. These are the questions I like to ask at this stage. So on a scale of 1 to 10, how likely are you to act on this plan? Right? So 1 being, you're never going to do it. And 10 being, 100%, no doubt in my mind, I'm going to achieve this. So why do we ask this? Well, because you could get useful information from both ends. So let's say she says a 5, right? On a 1 to 10 scale, how likely are you to do this? I'm going to bet a 5. Okay, so what's keeping it from being an 8? And this is going to give you barriers. Ask for the barriers first, then get the motivational talk second. So what's keeping it from being an 8? Well, it's going to be really difficult. I'm not going to be able to do this. I'm not going to be able to do that. Okay, we can do more problem solving around that. How can we help solve those problems? All right, great. What's keeping it from being a 2? Right? You said a 5. Why not a 2? Well, I really want to do it, and I think it'll really help me feel better, and it seems realistic. I think I can do this. Right? So you're ending with her telling you why this is going to work. So you've solved the problems, hopefully. You've come up with some ideas to solve the problems. And then she's telling you why she wants to make this work. So I love this question. I ask this every time in a primary care office that I come up with a behavior plan. And then you need a follow-up plan. That's the last step. Some kind of accountability. I'm going to check in with you. Right? The doctor's checking in with you. So not only do you have it on a prescription pad, not only is this my prescription for you, but you're going to have to come in here and tell me why it didn't work out for you if it doesn't work out. So you're going to set concrete goals before the next check-in, whatever that is. And so the plan is going to be specific to this kid. Not everyone needs to be seen frequently, right? If mom and the kid seem really motivated and the depression seems pretty mild, and it also might be transient because there's stuff going on at school that might resolve itself, is a very common scenario, right? Like 2 weeks ago, all this friend drama happened, and 2 weeks later, they're best friends again and Instagramming how much they love each other all the time. So it may not even need a follow-up. So you're going to set the follow-up plan based on what is common to your practice and how much is necessary. If this seems like it could be a really serious, intractable problem where she's been depressed for a while, she's not motivated to move forward, I recommend checking in sooner rather than later. Whereas if this is something where she can go and do it, then great. Like maybe call us if you need more help with it or something like that. Whatever is common to your practice, set a reasonable follow-up plan and let her know what you're going to talk about in the follow-up plan. I'm going to talk to you about this. I want to hear how this is going. So, make sure that we said you're going to do X, Y, and Z. I'm definitely going to ask you about that next time. You also want to have a plan for worsening of symptoms, right? Especially I'd talk to mom in this case. Her too, but Jane is 12, so you want to talk to Jane and mom. what are the symptoms that we're looking for? If she starts talking about dying, give me a call. If she starts talking about killing herself, go to the ER, right? You may not necessarily have that conversation with everyone, feel it out, but talk about the symptoms that you want them to look at based on each individual case and give them a plan, what they're gonna do. Whether it's just call me and then we'll talk about it and we'll get you in here or we'll figure it out. And so some options are, you can return for another visit, you could have a phone consult, you could go straight, here's a referral, UBHC is right around the corner. If things get really bad, you could always go to them. Whatever is your plan, whatever is your practice, but just make sure that you have a follow-up plan in place for all of these things. So other considerations that I definitely want to cover here in brief, if a patient is suicidal, send them to the ER. Don't go through this whole thing. Right? If you find out she's thinking of killing herself, let the ER assess her. If a patient seems psychotic, less likely in a 12-year-old and harder to tell in a 12-year-old. You still have some very immature 12-year-olds who have like all this magical thinking stuff. But if you think that this kid is hearing things that other people don't hear or seeing things that other people don't see or has some very weird delusions going on that you just can't understand, or if her thoughts are all over the place and you're not able to make sense of what she's saying, especially if you know her a long time and this is a change, this is the time to, this might be an ER call if she's suicidal with psychosis, right? So those are situations where you just want to go to the ER or the crisis center. You could always call HUB, just kind of skipping down to the bottom, you can call HUB for a consultation too. So you can ask us, call, Cynthia's right here, she manages the HUB line. She can give you advice as to next steps as well. So there are tools to help you make these decisions. But generally speaking, you should not be dealing with suicidal patients. Send them to the ER to get assessed by specialists. If the depression worsens, something to consider, you may not want to prescribe an SSRI right away for mild depression. It might clear up very quickly. But if this is going on and 3 months later she comes in and she's still feeling depressed, you might consider prescribing an SSRI. Fluoxetine is the first-line treatment. Meta-analyses, there's more data on fluoxetine than any other SSRI for adolescents, showing that it is more effective. There are other recommended SSRIs, whereas paroxetine and SNRIs have been shown to have, they're effective, but they have more adverse side effects and are not recommended in an adolescent population. And you want to talk to kids and parents about how long it takes to work, treatment adherence. I can't tell you how many kids take it when they feel sad. And I know that their doctor has talked to them about it. I've talked to them about it, and they still do it. I was feeling really sad, so I popped two Prozacs. Like, no, it doesn't work that way. I was feeling good this week, so I stopped taking it, and now my stomach hurts, right? Like, no, that's not how it works. So make sure that they really understand how it works. Do a good amount of psychoeducation on that, and the type of effects that they're going to, side effects that they're going to look for, and especially suicidal thoughts, because it can increase suicidal ideation. And the HUB is a 24-hour, 24/7 hotline that you can call. We have a psychiatrist, a child and adolescent several child and adolescent psychiatrists on our team, so you can talk to us if there's more complicated prescription issues with the SSRI, if you just want to consult on that. If you want to talk about care coordination, right? Does this person need to be in outpatient mental health? We can help make a referral. We can bring him in. We could do assessment. Even just talking about like triage next steps. We have people who can give advice on that, answer your questions in real time. We're working on telehealth options too. So lots of help available to you in going through this decision tree. And then very briefly, I want to point out that there are guidelines for adolescent depression, and they have a cute name, GLAD PC, for all these depressed kids. And so the American Academy of Pediatrics put these out recently. They include a flow chart that shows care management, and then another flow chart looking at for prescription medications, when to prescribe your first SSRI, when to prescribe adjunctive therapy, in terms of medication. So it's an excellent resource, a lot of details there, so I recommend that you check these out too. And so we have time for another case. We have John Doe, different family, same last name. We have a lot of Does who come in. So John is 10, and he has asthma. He's had asthma for a while. That's one of the main things that you're monitoring with him. And so he comes in that his asthma lately has been getting worse. He's been having difficulty sleeping, and he's been feeling nervous and tense often. I'm not going to make you guys go through the whole differential, mostly because you'll give me all kinds of medical things that'll be way over my head. But in terms of thinking through comorbid anxiety, really, really common. Anxiety is a huge issue in youth, whether it's subthreshold or meeting the criteria for a formal DSM diagnosis. And it's really common with kids who have asthma, GI complaints, dermatological complaints, headaches. Anytime you have all of these physical symptoms, they really promote anxiety. Kids with allergies have tons of anxiety, especially food allergies, right? Because it induces anxiety. And genetically, a lot of these kids tend to come from anxious families. Anxiety increases all these physical problems. The physical problems increase the anxiety. They really go hand in hand. And so whenever you see kids with some of these chronic physiological conditions, really in the back of your mind always wonder, like, how much is anxiety playing a role here? Not necessarily that the asthma is not real, I do not mean to imply that at all, but just if we got your anxiety under control, your asthma might get a little better too. So you do the same screeners. No, not depressed, no thoughts of death. Internalizing subscale is like middle range, so this kid is experiencing a good deal of anxiety. No attention and externalizing symptoms. Not endorsing drugs and alcohol. And one adverse childhood experience. He had a household member who went to prison. So this kid is feeling some anxiety. 32% of teenagers in the US have an anxiety disorder. 1/3 of kids in the US meet criteria for an anxiety disorder. Now the impairment is a lot less, right? 8% have severe impairment. So most of these kids are just really anxious and tense. And it's not hard to meet criteria for an anxiety disorder, let me tell you. If you feel distress and you have anxiety, like, that's basically what the criteria are. So you have a lot of kids who are feeling distress, who are really nervous and tense, but it's not necessarily impairing their functioning in a huge way. More girls than boys. 20% of the patients who are going to walk through a primary care clinic, so this is adult and kids at this point, are going to have some kind of anxiety disorder. So this is really common, and like I said, it exacerbates a lot of physical symptoms too. So it's important to deal with. So number one strategy in a primary care clinic is going to be relaxation techniques, and I'm going to teach relaxation breathing in particular. It's been shown to reduce anxiety in people with chronic illness. So this is a really good thing even if the person is not endorsing a huge amount of anxiety. If you ask about it, a lot of chronic illnesses, you have to be a little anxious if you're going to adhere to all the treatments that you have to. Anxiety is not necessarily a bad thing, but if it's keeping them from sleeping, then we might want to deal with that, right? It decreases stress. It can help with depression. It improves sleep, even chronic insomnia. So asking about sleep and then maybe trying a breathing technique at night can help with a whole lot of things. It's great for pain management, especially with kids. Headache pain, a lot of these relaxation techniques can really help with that too. So this is not just for anxiety, it's for a whole host of issues. Now it's important to note that if the kid is meets criteria for generalized anxiety disorder, so what is this? This is pervasive worry about everything. What's going to happen if I do this? Yeah, but then I'm going to do that. And mom is not going to come home. And then I'm going to and if I do this, then I'm going to fail out of school and I'm going to end up not getting into college. I'm going to live under a bridge. I'm going to end up a crack addict and I'm going to die at age 30. And you have like 10-year-olds who talk like that and you look at them like, what? You are so that like telling them like just breathe is not going to work for a kid like that. That's a referral to an outpatient mental health clinician. That kid needs a lot more cognitive therapy. You could teach them the breathing technique too, because this is an element of most CBT, cognitive behavioral therapy, treatments for anxiety. So you could teach it to them. It's not going to hurt, but it's not going to solve. If you have a kid who's like a little one who's really worrying about everything, you got to bump it up. But for most kids who are feeling like what you would consider a normal amount of kid anxiety, this is a good treatment. So deep breathing. You could call it a lot of things. People call it belly breathing with kids, diaphragmatic breathing, square breathing, because some people do where you like have equal amounts of breathing in, holding, breathing out. A lot of people focus on using your stomach when you breathe. Some people really feel like the nose, breathing in is important through the nose versus the mouth. My philosophy tends to be, however they do it, it's like not super important. If they breathe through their mouth, they breathe through their mouth. If they're going, then that's not good. But as long as they're breathing in a fairly relaxed way, I wouldn't get too hung up on like making sure that their belly is rising and falling, because then you can really frustrate kids, and you don't have a huge amount of time to keep practicing this. I like to do where you breathe in for 4 seconds, hold for 2, out for 6. It's a little more counting. Most kids can keep up. And the important thing is to have more of an exhale than an inhale. Your heart rate slows down, you calm down on the exhale, not on the inhale. The hold is also important because it kind of resets everyone. So they really should feel a little lightheaded, out of breath. That's okay. You can tell them that's normal. So I'm going to have us do it exactly like how I would do it. As I'm stuffy-nosed and coughing, we'll all soldier through together. So all of you are my kids in my office. You're all John Doe. So I'm going to teach you a breathing technique today, relaxation breathing. What we're going to do is we're all going to breathe in. I have to breathe in through my mouth because I can't breathe in through my nose right now. Breathe in whatever's comfortable for you. We're going to inhale for 4 seconds. We're going to hold for 2 seconds before doing anything else. And then we're going to exhale for 6 seconds, and I'll count you through it. You ready to go? Okay, so inhale. Hold. And out. 3, 4, 5, 6. In. Hold. And out. One more. In. Hold. And out. And I like to ask, how are you feeling? And a lot of times people are like, oh, I already feel it, right? I feel a little, sometimes they're like, I feel woozy, I feel lightheaded. And you say, that's normal. That's okay. You're getting a little less air. It's slowing you down. We don't want you to like pass out or anything, but it's okay if you feel a little lightheaded. Sometimes I have kids who imitate me. I do it very loudly and demonstrably. So I will stop and say, like, if that's comfortable for you, that's awesome, but you don't have to do it like me. I'm doing that for the purposes of this. So, right? Sometimes you get kids who like mimic exactly what you do it. It's okay if they don't mind. And so then I do the whole prescription thing, right? So in order for this to really work, right now we're calm and cool, and we started at a pretty like low anxiety state, so you might be feeling it faster. But really you're going to have to do it like 5 to 10 times to feel anything. And then also tell them, when are you, oh, yeah, I have this on slides. When you're anxious, when you're nervous, when you're angry, when you're feeling like huge emotions, how easy is it for you to just stop and breathe? Right? And most kids have enough awareness to be like, yeah, that's really hard to do, right? And sometimes you're like, oh, I could do it. And it's like, I can't do it. When I'm like really upset, it's really hard to slow down and stop and breathe. That's going to be hard too. So you have to practice it several times a day in order for it to become automatic. The more automatic it is, the more likely you're going to be able to do it. It's like playing the piano. It's like playing sports. It's like anything else. You have to practice until it becomes natural. And so then you like get out your prescription pad and you say, okay, I want you to do this twice a day. Once before bedtime is a really great time to do it. If parents are around or guardians or whomever are around, y'all can do it together before you go to bed. It can be part of a nighttime routine, and it can help get them more tired and make sleep more routinized anyway, which is a good thing. And then some other time. When's the other time during the day you're going to practice? Sometime when you're feeling calm and cool and not anxious, and you have them choose the time, right? So every day you're going to do it twice. You're going to do it 7 cycles of breathing twice a day. The first time is first thing when you wake up or whatever time they say, and then the second time is right before bed. Mom, you can practice with him? Awesome. What's going to keep you from achieving, right? What are the barriers? Go through all the same motivational stuff. And just make sure that they know that then when you're feeling really anxious, you're doing all this practice and you can do this breathing technique and it really will help. But it's not going to help if you don't practice, right? Because then you get the breathing that looks like this. And the asthma happens and then they're freaking out, right? And you did not do them any favors. So just make sure you emphasize the practice. And don't forget those motivational interviewing skills. So you can do the same engage skills, asking open-ended questions, affirmations, reflections, and summaries, elicit, provide, elicit, the change talk. How likely are you to do this? Is this something you want to do? Do you like feeling anxious, right? Do you need to, what would need to change for you? What are your reasons for doing this? Getting them to come up with this plan together. Especially around the, like, when's the time you're going to practice thing. You could do 1 to 10. How likely are you to actually practice this? Oh, it's a 2, huh? Tell me all the reasons why you're not going to do this. All right, so maybe that's not a good time for you. Is there a time when it wouldn't be a 2? Oh, it's a 5 if you do it at, like, in the middle of class. Well, that's great. What's going to keep you from doing it? Yeah, you don't have to make it this big, exaggerated breath. The nice thing about this is you can practice, and no one needs to know. Just breathe really, like, quietly. You know, you don't have to breathe like your crazy doctor who's doing this loud stuff. Do it really quietly. So go through all those motivational interviewing skills with this, too, and it makes it much more likely that they're going to comply. So to summarize, behavioral activation is an excellent, excellent technique that can help depressed kids start to feel a little better. It's good for low levels of depression if they're actually likely to do it. You still want to do some watchful waiting with them and maybe decide to add an SSRI or some other therapy, maybe outpatient referrals. But this is a good place to start if you have a kid who comes in with some level of depression. You want to use your motivational interviewing skills, I would say, for like anything that you're telling a patient to do. They're more likely to do it the more collaborative the process. And relaxation breathing for lots of physiological issues as well as anxiety, depression, and other things. This is a great tool too. If symptoms persist in these kids, you can, or if you have questions, you want to make referrals, right? Sometimes it's very obvious as soon as they come in the room that this is not something that you are equipped to deal with. Refer them to us, give us a call at the hub. We have our hub team right here in the front, so they're happy to talk to you about it if you have any questions about hub. And so that's another tool that's available. So thank you all so much. It's been a real pleasure to chat with you. And I wonder if anyone has any questions for me about any of this. Yes?
Very nice overview, and I appreciate practical tools. The question I have is, first case was a 12-year-old. When is a child's mind primed or ready for motivational interviewing? And should it be adapted for the younger child?
That's an excellent question. I don't have a research-based answer for you, but from my clinical experience, I can tell you, you can adapt most skills to really, really little ones. The younger they are, the more directive you have to be just in general. They're used to everyone in their world telling them what to do. But if you've had a 4-year-old who's still kind of trying to assert his or her independence, it's really nice to ask questions to give choices. Instead of asking maybe open-ended questions like, what would you like to do? You could say, you know, I have some really great ideas for you. Would you like to do A or would you like to do B? And you're still making it collaborative. You're still bringing them in and giving them that autonomy, but it's a more limited autonomy. It's something that they can handle. For something like behavioral, I mean, if you're looking at really little ones, a lot of this stuff might not apply. You could do breathing techniques with a really little one. Behavioral activation is just talking to parents or guardians or whomever and saying they need more activity in their life, like make that happen. I wouldn't necessarily have the kid be part of that plan. So I think it depends on how much autonomy the kid has in his or her own life, and that's where you make your judgment. I mean, unfortunately, some of these kids live really independently. You could have 8-year-olds who are home alone a good chunk of time, and so you really do have to engage with them. You're not necessarily going to say, like, Mom, this kid should be out playing soccer because Mom is working 15 hours a day and the kid is alone at home. So what can we do other than play video games while you're in your apartment, right? Like, what's something else you could do? Do you have a Wii game that you could do that's a little more active? Coming up with different, and like asking them because they might have some ideas. So yeah, adapting as is. I hope did that answer your question? Okay. Yeah.
So I have to confess, I'm a failure at motivational interviewing. And as I'm watching, I'm thinking, what am I doing wrong? I have a group of patients, they're teens and adults, who these are PKU patients, who have to follow a really strict diet and adhere to drinking the stinky formula and change their lifestyle. And every time they come to see me, I think we've agreed on a plan, we've talked about it, spent an hour and a half talking about it.
Oh, wow.
They say they're ready, I feel like a cheerleader, I'm like, I'm gonna do it this time, you're gonna do it. And then they come back next year and they haven't done any of it. And it's like 95% of the time they haven't done it. So I'm failing them. Then I look at a 7-year-old who was having problems, he couldn't sleep in his own bed. And I talked to him about it for a while, and we signed a contract that we were going to have a plan that he was going to sleep only 2 days a week, this week in bed, and then the next week, no. And, he signed the contract, and he completely did what he said he would do. Should
Wow.
we have patients sign a contract?
I think that's a judgment call. I think writing things down always makes it more likely that people are going to adhere. I think signing
Send the patients the notes with all our plans.
Right.
You said we were going to do this and this and this, and they get it in the mail, but I don't know that they read it.
If you have a 16-year-old, he or she might not care about signing a contract with you, whereas for a 7-year-old, that's like a really big deal.
We have it as chart, they have like you saw.
Right. So again, like the status may work differently depending on the age and like how important that kind of stuff is for the person. I would say for the older kids, right, for the PKU kids or teens.
And adults.
And adults.
50-year-olds that aren't listening.
So for the really big kids, right, like, why aren't they doing it?
It's hard.
It is hard, but
Change is hard.
more specifically to them. Change is hard, and yet we all have our very specific reasons why we don't
They
change.
always have like these, some of them have they have very poor executive functioning. They come up with really crazy reasons why they can't do it. My dad ate my salad. You're 37 years old and your father ate your salad. But you know what I'm saying is but they come back with some really weird reasons why they.
Yeah, and it might be too much. Like a lot of the problem is if you have a really complicated treatment, that you're going from 0 to 100 like that, and you have these low executive functioning 37-year-olds whose dads are eating their salad, and all of a sudden they're expected to adhere to this really complicated treatment regimen. Like, that's not going to work. Is there a way that you could simplify it? And the answer may be no, right? But is there any way for each individual you could simplify it? What is the most important thing I want you to start this time?
Instead of giving them 3 things to do, give them 1 thing.
Right. If they're low executive functioning, maybe they can only do 1 thing. 3 is usually the max. Sometimes you don't have that luxury because they're so ill they need to do a lot. In that case, where if he's living with dad, can you bring dad in?
Oh, the 37-year-old is not living with dad, but he ate her salad anyway. No, she
Oh.
has 3 kids.
Oh, okay. Well then, never mind. Scratch that plan.
They come up with these like crazy things about, well, I had a fight with my boyfriend, so I ate a steak. I'm like, okay, that wasn't good.
So I have 2 pieces of advice in this case. So the first is simplify, simplify, simplify. Make it as easy as possible. Even if they need to do more, let them have success at something and then give them a really short follow-up period. So if you meet with them again and, if
See, that's the problem. I see it once a year. So they got a whole year to degenerate.
that's a tough one too. If you can meet with them and not give them an hour and a half of your time, meet with them and give them 10 minutes, 15 minutes, right? I'm meeting with you and all we're doing is talking about, did you do this? No. What can we do to make you do this? 15 minutes on the clock. You can put a stopwatch. Like, don't give them as much time. but make it more frequent. That's more likely to have adherence and ramp it up. And the second thing is try and, for your own thought process is, what's at the core of all of these excuses they're giving you, right? Each individual time there's a different reason why it doesn't work. What's the bigger picture? Why isn't this working for them? And like, yes, low executive functioning is a reason, but in this individual's life, is it just that they don't want to do it? Is there just a ton of ambivalence, right? So maybe you need to step it back on the stages of change, right? You need to really dial back your expectations. You need to ask them more questions about what's preventing them from this. Let them tell you first all the reasons why it doesn't work for them. And don't solve their problems. Do you all like have that important person in your life where like you have all these issues and you come into them and you're like, oh, let me tell you about how hard my life is. And they solve your problems for you. Yeah, husbands are really, not to like gender stereotype, but husbands are really good at this, right? You just want to like vet. You just,
don't talk.
right, you just want to vent. And they're like, but here's all the reasons why you could fix this. And you're like, but no, just stop, right? So if you think about, you can be the anti-husband in this situation and just let them vent and say, yeah, it's really hard. That's really difficult. And give them like 2 minutes to just like vent. And then kind of step back and you say, okay, I let you air your grievances. So what can you do? What would be doable? And how can we make a little bit doable? That's really hard. I agree. That's going to be tough to do, your plan. Like, what are all the reasons it's not? Like, give them lots of opportunity to tell you why it's going to be so difficult. And then hopefully you can work through it and let them problem solve around it. Because if you keep solving their problems as they give them to you, then I find the excuses get more and more ridiculous. The more and more solutions you give them, because they don't want you to solve their problems all the time. They need to solve them themselves.